Hi, everybody. This is Rajam Roos, the founder and SEO of the San Diego Pain Summit, and I'm here for this portion of the Clinical Pain Mastery Summit with Neil Pearson, who's joining us from Canada, I believe British Columbia, correct?
Right, Rajam. Yeah.
And Neil is a physiotherapist and clinical assistant professor at the University of British Columbia. He is a yoga teacher, a yoga therapist, and creator of the pain care yoga training programs for health professionals and yoga therapists. He is also the founding chair of the Physiotherapy Pain Science Division in Canada, recipient of the Canadian Pain Society's Excellence in Interprofessional Professional Pain Education Award, faculty in yoga therapist training programs, and also an author. He is the co-editor of the book Yoga and Science in Pain Care, Treating the Person in Pain, which will be available next month in August 2019. And you can read the rest of everything that he does. He has a lot more accolades on his bio page. And so, Neil, thank you again so much for joining us. And I'm really curious, if we're considering explain pain education as a tool for increasing therapeutic alliance, what do you have to say? So a lot of people say pain education doesn't work if we don't have a therapeutic alliance.
Mm-hmm.
What is it that you've mentioned before about pre-contemplative or contemplative? What does that mean?
Right. Well, thanks so much for the great introduction on that. I think part of the reason that this topic is important is because explaining pain or doing pain education is difficult. We're often working with someone who's heard a lot of different messages before, seen a lot of people before, come into it with their own beliefs, and we're pretty much sure that the vast majority of people don't sit around thinking about what they think about pain. And so typically what our experience is that that pain is a medical condition and we need somebody else to fix it, or that the pain is whatever pain you have is so directly related to exactly what's going on in the tissue. Right? We know people have those beliefs. And so sometimes when people come in to see us and we're attempting to give them pain education, the clinicians will say, but if we don't have a good therapeutic alliance with the person, they're never going to hear a new story, right? So I have these beliefs, and I'd like to be able to get you to have the same beliefs. But if we're not friends, if we don't have an alliance in some way, how could it actually work? And so I think in terms of the words pre-contemplative and contemplative, so this comes from a thing called the trans-theoretical theory. Sorry, trans-theoretical model. Sorry.
I'm not the only one skipping over words.
Exactly. And it has to do both with the stages of change that we go through, but also the processes of change. So if we just look at the stages of change, so people typically go from being pre-contemplative, not even contemplating that something, say, clinically would work or that something is true, to then contemplating an idea. Maybe I need to think about this more. And then people move from there to a point of being determined to change, and then they move from there into actually action to change. And then if a person had this nice smooth path, which nobody really does, they'd move into maintaining that change. So the research around this has been done with people who we're trying to work on single behavioral change, which is an issue around pain management because it's not single behavior change. So looking at people changing their diet, smoking cessation, that sort of thing. And what they found is that when a person is pre-contemplative, not even contemplating that this would be a good idea to make this change, or when a person is contemplating, when the person's thinking, well, the change may be good, but it's interesting, when we're first contemplating changes, we're actually contemplating the benefits of not changing and the consequences of changing. That's usually where we start with contemplation, which was really great. This research showed us this. We would have thought people would have contemplated pros and cons of both sides, but that's not where we start. Anyway, the research they've done around single behavioral change has been pretty clear that there really are only two effective ways to shift a person who is pre-contemplative and contemplative, and those are to provide the person with knowledge and to build the therapeutic alliance. And so you see the sort of the twist we get into here when we hear people saying the person is pre-contemplative that they could actually change pain or that movement is the right thing to do. And so the pre-contemplative, we need to give them education, but if they don't have a therapeutic alliance, the education won't work. And I really think what
That's
we
kind
need
of the basis for everything, is that therapeutic alliance before anything can happen. Is that
exactly. And so one of the things that I found over the years of playing around with this is that a lot of times I actually use the pain explanation or the pain education as a way to actually build therapeutic alliance. It's an opportunity for me to show the person that I've listened to them. It's an opportunity to, you know, come into their reality and talk about it from their point of view, and to build trust. And I think that we aren't really thinking of it that way. You know, right? We think of it as it will work, yes or no, if a person is, if we have therapeutic alliance. And it's harder to do this, of course. But I think, you know, the ways to do this, the ways to provide this education, number one, it's about listening, right? It's about listening to the person in front of you and using their language. I mean, that's one of the beautiful things is that if the person's told you their story, right? If you're doing one-on-one education, they've told you their story, so you've already heard their language. You know, did they say something about something being cranky, or you know, how do they describe their pain? And if you can start to use that language in your explanation, you're building more of a relationship. The person will feel heard, which will be really, really important.
So what does that look like? So if you have a patient come in and you're not familiar with using the therapeutic alliance, but you kind of have an idea, especially after listening to a lot of these discussions, what would that look like for your patient when you come in? You're listening to them, and then what would kind of that, like an example of that process look like?
You mean an example of listening?
An example of communicating from that basis of a therapeutic alliance.
Right.
If you want to incorporate pain education into that.
Right. Well, and I think if I could give you an overview, and I'll get to this couple of specifics. If any of the people listening to this have an opportunity to take a training that's like motivational interviewing, there's so many parts of that that become really important. So one of the things that they talk about, a practical thing, is to roll with resistance. So when you've said something and the person starts to argue back or argue against you or resist what you said, don't argue back, right? What we need to do is understand that there's other messages. Like the person may actually be resisting because their filter may be, you're saying it's all in my head, or their filter might be saying, you're saying it's not real, right? And it would be like, there are some times, even, you know, the best of us doing this stuff with educating people about pain, that the person will give you that, you're just one more person telling me that it's not real or it's all in my head. And one of the very practical things that we could do is leave that alone and actually go to, what are you actually trying to do? So my response to a person would be something like, actually, what I'm trying to tell you is that pain is changeable. Or we think of like, what are the key messages of explain pain and pain education? We want people to know that we believe that pain is real and that it is a physiological thing. We want people to know that pain is changeable and that they have some sort of influence on it. We want people to know there's multiple ways to change the pain, right? There's not just one, right? So there's a whole bunch of things that we're trying to do with this, within this education. And when a person's filter is interpreting us wrong, I think it's important not to go into that argument. As another practical example, this is on the don't do side. This is what I believe. If a person is saying to you, the reason that I have pain is because of this disc thing, that's what the MRI shows. I really, really think one of the things that we don't want to do is pull out our research to say, look at the stats on how many people have that problem without pain. Because that means the person told you, this is what I believe, and then you said, no, you're wrong, right? So we need to find a way to roll around that. We need to find a way to, you know, discuss it. And this is one of the places where metaphor becomes important, and story. Because the whole idea of story is to provide the person with an experience that's inconsistent with what they believe already, right? In this case, that's what the story for. So the person believes this. If I can give a person a story about pain that doesn't match up with what they just said, and the story is good, and the person gets involved with and engaged with it, at the end of it, they're in a place of cognitive dissonance. And that's one of the things that we know will help a person start to make the shift.
Do you
We
have an
just,
example of that?
an example of the disc. Well, we could start with an example of saying, um, sometimes the body gets injured and the nervous system becomes sensitized when it becomes injured. And if the body does what it normally does, I'm pretty sure that most of the times what the physiology of the body goes, that's old news, I don't need to tell you about it anymore, right? But there are some times when we get injured, and for some reason the system doesn't really do that. And one of the common examples of that would be someone who's been smacked in the shin. I would say, you ever been banged in the shin really hard? Most people go, yeah.
I've banged myself in the shin.
Yeah.
I've banged my shin into stuff.
Yeah, exactly, right? And so can you remember, 5 or 6 months later, you still touch that spot and it still hurt? Well, what's that from, right? What that says is sometimes we do injure a body, and sometimes it does take a long time for the pain to go away, even though the tissue is getting better all that time. Right? Because if we did an MRI of your shin 5 or 6 months later, the MRI would look fine, yet it still hurts. That's a real thing. And so it's possible, I can't tell you for sure, but it's possible that when the disc bulge happened, that the nervous system got really, really excited about that because it happened quickly. And that normally what would happen is the nervous system over time will stop paying so much attention to it. But potentially in this instance, it hasn't. So what we need to do is figure out how could we work with that. So it's trying to find, I don't know if that example would work with a lot.
That makes sense. That's a good, I mean, it's hard to come up with one because interaction is so fluid. So
yeah,
but I think that makes, I think that makes a lot of sense. And it reminds me of Greg Lehman gave a presentation and he was talking about, what someone asked him, what do you say if someone brings you their x-ray or MRI and they're like, this is why I have pain. He said, yeah, I just say, well, yes. And then he goes on to talk about like what you were mentioning, but that's a really good point about, because if you bring out that research and say, but look at this research that shows all these people have this and no pain, I could immediately see how that would put somebody on the defensive.
Right. And that's so when a person is pre-contemplative and contemplative, it's helpful to guide a person towards change. And in one of the other ways that we can look at pain education and building therapeutic alliances, to stop trying so hard to change the person's belief system or their thoughts, and start to provide it in a way that you're saying to the person, isn't pain, I can't remember, I think somebody says this, isn't pain weird, right? I usually go with pain is complex and we need to think about it from multiple points of view. And then so I start to talk about pain as being protection, and then we start to talk about pain as an experience, and we start to talk about pain from different things, and nowhere getting near towards the person's belief, just talking about it in different ways, and hopefully in an engaging enough way that the person finds it sparks that curiosity. Maybe there's other ways I need to think about pain that I haven't before.
Do you think it's useful at all to ask the patient what their belief is about pain, or do you think that's not as important to talk about?
I've actually never hit that right on the head, but I've always talked to people about what do they think about where this can go. So here's where we are now. Do you think that we can help you move with more ease? Do you think that we can regain more quality of life? Do you think that we can actually change the pain itself?
I see. So more thinking about where do you think you can be beyond this point?
Yeah. But I love that. I got to think about that more.
Someone just mentioned it in another discussion on this clinical summit. So I thought that was interesting too.
Yeah. I mean, it's interesting because one of the things I'll ask people is part of the pain education is actually, this is the way I guess I ask it is, what's the purpose of pain? And it's really, really fascinating. So many times people look at me like I'm an idiot. It's like, well, pain's there to tell you've been damaged, of course. Right. So, that's where most people start with that. But I got to share a sort of quick story about the x-ray thing, because this happened a couple years ago and it was so cute. So usually when people get sent to me, they get sent to me because they have really big, complex chronic pain problems. And this particular person wasn't quite like that, but she was 85. And all the referrals said that, that's her name, her phone number, she's 85, and she's got this low back pain stuff. And so she comes in, the very first thing, I don't even get really any question out of my mouth other than saying hello. and this is who I am. And she says, you better read this. And she pulls out of her purse a bunch of pages. So it was actually 5 pages that had been folded up, and she unfolds them all and she hands it to me. It's a 5-page radiological report. So some radiologist must have been pretty bored that day, because there's a page per motion segment in the lumbar spine.
Wow.
So, but she's 85, so there's a lot to write about, right? And she actually has a grade 3 spondylolisthesis, a degenerative spondylolisthesis, right? Anyway, so I'm reading through this, and it's all circled and marked up and all this stuff, and I'm like, at the end, I'm like, oh no. And so I said to her, have you read this? And she said, yeah. And I said, well, what do you think it means? And she says, well, it means I got an 85-year-old back. Said,
Good for her.
Why do you think you have back pain? Well, I have back pain because it was spring and I hadn't been gardening all winter, and I went and I gardened for 3 hours. My back got sore. And I'm like, this is fantastic.
Did you hire her?
What I'm usually running into, right? But she came in with the right story, or she came in with a story that made the most sense based on it. She hadn't medicalized her pain like we so often do, right? And I think it's really fascinating. A story like that is something that Lorimer and David have talked a lot about. Using story, and the idea of the story is to give a person an experience that's inconsistent with what they already believe, right? Because when it's a story, you get engaged with it. And it's another thing about pain education that I think is really, really important, is for us to consider that we can actually give a person an experience that's inconsistent with their beliefs about pain in many other ways besides talking to them or showing them pictures, right? So even because most people come in thinking that pain and tissue damage match up and you really can't do much about it. Even if someone did I know there's a lot of controversy about needling techniques, but if you did a needling technique or you did a manual therapy technique, and at the end of it, the person's pain was less and their movement was better, we need to realize around pain that the person probably isn't putting this together, because the person's thinking, you fixed me. And what we need to do is say to them, that's fantastic, your pain changed, right? And then say, let's look for the other things that we can change this, because this is the stuff that the person doesn't understand or believe. The person believes they need you. And often, even when we change it, the person's thought is, you're just covering it up. But if we can get the person to have less pain and better range of motion, and then get all excited about the fact, wow, that's so amazing, your pain changed, that's contrary to the person's belief, right? And you just gave them actually an embodied, a physical experience that was inconsistent with their determination of how threatening this was, or what was going on.
So that's like self-efficacy, right? Like giving them the control to handle it themselves.
Yeah, and sometimes we want to get people there, but I think one of the things that we've missed is that sometimes to get the person to a place of self-efficacy, to believe that you can actually change it yourself, you might need to start with, the pain is changeable, or my movement is changeable. And if a person's got a really strong belief that those aren't possible, that us jumping right into getting the person to do something, right? Jumping into, like, I teach people contemplative practices, body awareness, meditation, breathing, all that stuff. And sometimes what is way more effective is for me to get my hands on the person, do a little manual therapy that will change the pain, give the person some more ease of movement, and now sort of go from there. Okay, yeah, it changed. Let's see what you can do to change this too. Because there are people in the world, if you change their cognitions, it doesn't actually change their behavior, which is something we have to be careful.
Explain that a little bit.
Right. So the whole premise of cognitive behavioral therapy is that if we change people's cognitions, it will lead to behavioral change. And the reality is that it doesn't always. So an example could be from someone who's afraid of a spider, right? Or, afraid of spiders. The person's sitting there in the room. There's lots of other people between the person and the spider, but the spider's on the other side of the room. And someone goes over and takes a glass jar, and puts it down the spider. Well, this person is now knows that they're safe, and says all the other people between him and the spider said, if that spider gets out, I'll kill it, right? So the person can sit back and know they're safe, and yet still have a behavioral response to it, right? So, and I think it's one of the things that we need to, I believe, this is true, just I believe, that the more stressed we are, the harder it is to change one aspect of our existence with another. And so I think we with pain education, there's an assumption that if you can understand it differently, it will change the physiological response to that movement or to that stressor. And in time, I believe it will. But I think we're starting with this assumption from the best way to get a person to understand that change is possible is give them the knowledge and then the behavioral change. But one of the things I'd say is we need to think about has the person in front of us been trained in learning like we've been trained to learn? We've been trained to learn to sit down and listen to people talk, read books, and look at pictures. But a lot of the patients that we have coming into us may never have learned through listening. They may be way better at learning through doing, right? So if we can then say, okay, there's another way to explain pain. Because the point of explaining pain is to give the person experiences inconsistent with what they think, right? Get the person to understand pain in a new way. Well, you can get people to understand pain in a new way by having, it's not really quite right, but an embodied experience. I know cognition is still an embodied experience, but I mean an embodied experience where you feel it in your body, right? It more than just thinking it, you feel it. I just experienced that I could move my neck further, right? And you did that for me, or I did that for me, but I experienced it, so that to some people is the truth, right? Because this thing to most people is the most real thing that exists, way more real than thoughts and emotions to most people.
And just to touch back on what you're talking about, how people have different learning experiences. And I've seen that a lot when I had my massage practice. You'll be explaining something or having a discussion with someone, and they just can't get it, and then you have to shift and come at it from a different angle. Right. And it seems like the important thing is not to give up finding which angle they're going to see that from, and not get frustrated and be like, forget it, they're not going to even understand. Even if you're not trying to explain anything complicated or anything, you're just trying to talk about pain changing or something. It seems like it's easy for clinicians to kind of give up and be like, oh, we just have a communication issue, instead of trying all these different angles, to present the information.
I think that's so important. We need to set ourselves into our own place of being curious about what's required here to get this person to reconceptualize this or to experience it in a different way. And I think the idea of practice and repetition and recognizing that I think one of the biggest things about explaining pain to people is seeing it as basically like it's a technical thing, right? This is how you do it, and not realizing that what you're actually trying to do is work with a human being, right? And so in doing that, you're going to have to modify the way you do it and find as many options as you can. And also with when we start explaining pain, is realizing we're not going to succeed a lot at the beginning. I mean, that's a horrible place to be as a clinician, but the reality is that if you've not tried doing this before, it's going to take a lot of practice to start to get better and better, a lot. It's one of the things that I do, I have a mentorship program, and one of the things I do over 10 months is I guide people to actually who've never done a public education session, like a group education session, and I guide them to being able to do that. And it's one of the things we actually do there, which is different from a lot of clinicians, is I get the person to provide the education to someone who likes them first, and then provide it to someone who but who's probably going to be critical, right? And sort of work that way, or maybe provide it to a family member who doesn't think that you're an expert in anything, right? Before you.
That's not hard to find.
Yeah, no, exactly.
Especially your mom, right?
Exactly. It's hard for our parents to see us as having this great knowledge in this stuff. But anyway, sometimes we need to recognize is that, that's the difficulty of this. And that even though we can learn all the technical things and learn all the possible stories to give and do all the stuff, right? It's going to be hard to do the education. And what I would say is that one of the things we can do, though, is to step back and think, I'm a clinician. I already work with people. I've been trained in things that help to have allow people to move with more ease, to give them a sense of less pain. I'm trained in coaching. I'm trained in all this stuff. well, use that too. Rather than viewing pain education as this sort of thing that happens over here, but thinking, what are we actually trying to do in pain education? And so could I get those same things through what I already am skilled at? And so the idea is that instead of just using verbal and visual things as the educational agent, to use what we're already good at as the educational agent, I think will work for a lot of people.
For example, say if you're better at helping somebody find a movement that is, pain-free, or doesn't hurt them as much, then work with movement. If that's your skill.
Yeah, and I think movement is one of the very best ways to go, and people are going to really, really appreciate that, because probably I think one of the most unanswered questions for most people with ongoing pain is, how am I supposed to move when movement hurts? Right? Because when I teach doctors, because I do a lot of work with family doctors, they often say, well, why don't these people understand that they need to move more? I'm like, you've got the wrong question, because the people that you're talking about know that movement is good.
Mm-hmm.
Right? Because people try to move on their own. It's not like we don't have any idea. It's not like we haven't heard the world saying being stationary doesn't help, right? So people know, but the problem is that no one's really telling them. And the doctors will say something like, well, the research says that no exercise is better than the other. Well, yeah, but you still need to tell people how to succeed.
Yeah, because what does that look like? I mean, in their mind, movement might be to them getting up, which hurts,
Mm-hmm.
bending over, which hurts, turning to the side, which hurts. But they may not think about subtle changes in other directions or other body parts or anything like that.
Right. Yeah. Well, and the person, like the subtle changes, I think are really, really important. Is that, in terms of regaining movement, I think so many of the people that we worked with have had, the pain has been there big enough, long enough, that what the person has done is learn how to not pay attention. Or maybe they started as a masterful distractor anyway, but now the person that to carry on with life, what you try to do is disconnect. And if you disconnect, then you don't hear the alarms until they're really loud, right? And so, I mean, to me, that's one of the reasons why bringing contemplative practice in, teaching people to be more aware of their breath and their body tension and their sense of energy and the thoughts that are going on, the emotions that are going on, because all of those things are actually, I would say they're all protective mechanisms, or they're all potential alarm systems to listen to. But we get good at not paying attention to those. And I mean, the story I often tell people is, it's a little bit like, you're at work and you realize you really need to go to the bathroom, but you're busy, so you stay there. And then after a while you remember, oh yeah, you feel it again, but you stay there and you keep on doing this and doing this and doing this until, if you don't go now, you're in trouble, right? And so I think what we often do is, around pain, that's what we end up doing, is we get really, really good at, it gets loud and we push it down. It gets loud and we push it down. And after a while, we can't do that anymore. And my story to people is always, what do you think a sophisticated protection mechanism will do if you don't listen to it much? Right? And most people can sort of get that. Yeah, it'll probably yell. But anyway, it's that figuring out, that's not the path that works for everyone for regaining movement. But I think what we need to do is recognize that the person in front of us, if they're still there, they've tried movement and they couldn't figure it out. And so what we need to do is use all the different stuff that we understand about pain to figure out, how could we help this person. And I think that sort of to circle back to the idea of manual therapy and passive to the patient treatments, I think there's a really good rationale for using it when a person's stuck with movement. If you could use it and say to the person, we're going to do this so you can actually move with more ease. Because if you can move with more ease, we're going to get the chemistry changes, the pro-inflammatory cytokines and the endorphin change and all that stuff, serotonin and everything. They're potentially going to start to give you more pain relief. And so we use it's like giving you a cane for a sprained ankle. I'm not going to give you the cane forever, just for a while until you don't need it anymore. And that I think sometimes we need to figure out how to do that. Everyone recognizes we need to be careful that the person doesn't decide that that's the treatment and that's the thing that's getting them better, right? The passive to them work. But it's been really interesting watching the language of in the pain area of becoming sort of almost demonizing passive to the patient interventions.
Do you have an example of that?
Well, I think the idea of there's no great evidence that manual therapy is going to help in the long term with chronic low back pain, right? So therefore, we're not going to do it. But what if you did it with 100% the intention of this is to get your pain from here down to here so that you'd be able to move forward? And it's the same model. I actually came up with this idea more working with doctors because they were talking about opioids and tapering and all this stuff. And I'm like, hang on a sec. If you can give the person the opioid and you could teach them that the purpose of the opioid was to make it so that they could move more or live better, wouldn't that be good? And so we're actually getting a bunch of the doctors when they write prescriptions for whatever pain medication it is, instead of calling it pain medication and talking about it for pain, we ask them as they give it to the patient, before the patient has the prescription in their hand, they say, this is to help you move better. And if it hasn't helped you move better by next week, we're going to either change this or we're going to get you to see somebody like a physical therapist who can help you to move better.
I see. So as opposed to this is to like get rid of your pain,
right?
This is to help you move better. Wow,
right.
That's a shift.
Yeah. Well, you can see in the manual therapy world, the manual therapy research, we don't know because it's not often written about in the research study, but chances are it was provided with the idea is this is the treatment. And that the person providing it was thinking that this is what's going to make you better. And the person taking it was thinking this is what's going to make me better. But what if we were to do that same research, like with the opioids, and make it very, very clear, the point of this is to get your pain from here to here so you can do the other things you need to do to get better. And so I don't know the answer, and I want to be clear that that's Neil thinking. It's not research evidence. But clinically, it seems that it really, really matters because expectation and intention have an importance around this whole education piece.
What can you speak to about if you get a patient that comes in and they are, they're so fearful of movement or hesitant of movement, and say they don't necessarily need psychological counseling or anything like that. It's just, what are some ways that you can work around that to get them to at least get started, or that you have before if you've had someone come in who was kind of like adverse to trying anything?
And so when you say afraid of movement, they're afraid of more pain, afraid of more injury.
Yeah. If there are, yeah, yeah.
Yeah. Okay. Well, I guess the first thing that pops in my mind is the really big thing is I want to make sure that person knows that I believe them, that they understand that pain is real, and that I get how much pain they have. Right? Because if they're afraid of movement, chances are they have lots of pain when they go to move. And so one of the things that I might try near the beginning with this person, actually, there's a couple of different things. One thing I was thinking about is that what I might do is ask the person and say, okay, so imagine that I've injured my shoulder and it was 3 or 4 months ago and the pain's still really bad. And I know movement is good, and my physiotherapist, you're my physio, you're giving me my physio, and you want me to move my arm. But if I were to do my exercise for my arm this way, how do you think that would work out? And it's funny that there are some people, well, not funny, it's amazing that some people totally get that, is that, well, if I hold my breath and I tense my body up like that, that's not really going to help me to regain movement. Say, okay, so sometimes we can start just simply there and then move into let's do the other stuff that would actually calm this down. But then there are other people who really do need to have that cognitive foundation where they understand that pain has to do with protective mechanisms, and the more evidence of safety that we can create and the less evidence of danger, the more likely we are to be able to move with less ease. More ease. So
I was like,
yeah, whoops. But anyway, so I think there's sort of different ways. But the other thought that comes to my mind is, even when you do all that stuff, is that I think this is a time where we can actually use imagery. That sometimes with people, if the person can understand that, well, maybe the person's even said, just seeing other people do that movement hurts. Or if I just think about doing that movement, it hurts. Then we know there's a sensitization even in sort of that somatosensory cortex or somatomotor cortex, right? So if I could convince the person to actually use imagery, and when I use imagery, I actually grade imagery, not like the graded motor imagery, but it is still grading it, where we grade from third person visualization to first person visualization, and then up to a kinesthetic imagery.
Oh, so
And
you have them imagine somebody else doing it, and then they imagine themselves doing it?
yeah, so actually what I do is I get them to imagine themselves doing it as if they're watching themselves in a mirror. So I usually put the person right in front of a big mirror and say, I want you to imagine that person in the mirror, that's you, is doing this, right? So you can do third person by imagining that you're outside your body watching you. But because pain creates a whole lot of disconnection and in some people dissociation, just the psychologists that I've worked with have convinced me that it'd be better to get people to stay embodied while they imagine the body doing something.
That makes sense.
So third person is like you're watching yourself in a mirror. The way we do it, the first person is as if you're watching with your own eyes as it happens, and then a kinesthetic is to imagine the felt sense of it. And then some people we need to actually grade them up to putting a visual and a kinesthetic together before we start to move it. And when I'm explaining this to people, I'm explaining it a little bit like Olympic athletics, saying, if a person can only do this, right, but they can't go past that, sometimes what the coach will do is get the person to start to imagine being able to do that task a little bit more. And sometimes we need to even play with it in terms of imagery, of getting a person to imagine doing it with more ease. Because it's amazing, sometimes people imagine it, but they imagine it hurting. Right?
Oh, that's very interesting.
Right? And so sometimes what we have to do is say, okay, can you imagine doing it with less pain or with more ease? Right? And sort of play around with that. And it for some people, it works really, really well. There's two groups that's really hard with. The one group is the people who as children did aerial stuff. Because whenever they imagine anything, they do it all together.
What do you mean aerial? Like
so jumps and dives and spins in the air.
Oh, okay.
Okay. So, because you can imagine when that person imagines it, if you imagine a high jumper or a high diver, they're imagining third person, first person, kinesthetic. They're flipping between them all really, really fast as they're imagining going through the whole thing. And so that person is going to, engage their, somatomotor cortex, sensory motor cortex like this much. Right. And so what we're trying to do is say, can you start down here?
That's really interesting.
Yeah. So it's hard for some people to start there. And then the other is the person, I've had people who, as I'm explaining this to them, look at me and say, nobody can do that. And so there are some people who have never, ever had the experience of imagining themselves doing it, or they've never done it consciously, right, on purpose.
What do you say to that?
Let's go a different route, right? Like, why bang on this, right? The person's probably not going to come back. Although, as an aside, when I was teaching in Turkey about 10, 12 years ago, and I was telling them about treatment for phantom limb pain. And I was talking to them about the mirrors and all that stuff. And they were really interested in it. And so after I stopped talking, I said, well, if you don't do this, what do you do? And they're really fascinated. They said, what we do is we teach the person that the phantom is a product of their brain. It's not some evil spirit. It's nothing like that. It's that there's some mechanism, we believe, inside the brain that's actually created this phantom that hurts. And so they say when a person understands that, they ask them a simple question is, who's in charge of your brain? And the person is going to have to say, well, I guess that's me. And they say, okay, so what we want you to do is exercise, move your phantom. And so my comment to them was a similar what you just said, is like, well, what if a person says they can't do it? And they said, we just work with them until it does. And so they're really, really happy around the mirror thing because they realized that they were trying to get people to come up with a visual image in the brain, right, to conjure up themselves. But with the mirror, they could do it for someone who had no history with that before.
Yeah, it's very simple to see. I mean, you can see it right there. The reflection. Mm.
But it was really, really fascinating is they were using the same approach, but they were, and sometimes I said to them, how long does it take? And they said, we just stay with it until the person gets it. Right? It always works. If the person will stick with us, it always works, which is really fascinating that they were like, I don't know, it was 100%. That's what they're seeing.
And it could be their culture too, the sticking with it till it actually works and that sort of thing as well.
Yeah. And if we sort of circle back to the pain education stuff, is that this is an opportunity when the person does something like this. This is an opportunity to reconfirm what you've told the person. Right? This is our part of our job, is to be able to say, what are the common myths about pain? And then specifically this person in front of me, what do they seem to think about pain that's problematic? And then when you give the person an experience that gives a positive response, how could you come back and reinforce it? Because it's another thing about pre-contemplation, contemplation, determine, and action, all that stuff that most people miss, is that we don't start here and go here and then here like this. The average person moves from being contemplative or contemplating things into action and back into contemplation and back into action, something like 6 times before we stay in action, right? And it's another piece that becomes troublesome for us as clinicians, is because you're like, I already explained this to you, right?
Mm.
Or you're saying to your clinician friend, I've told them this so many times. To which, of course, me, as if I was your mentor, I would say, well, do it again, right? And find other ways to do it. Because if you've lived your whole life with this belief and someone come along and you trust them, you believe them, they tell you this, and yeah, you get it and you start to use it, it's not like that went away. Something could happen that seems inconsistent with this new idea. And so now you're back here again. And so I think this is another thing about explained pain that we need to do, is we need to recognize, not only do we integrate in what we do, but we continue the whole time, recognizing that the person in front of us has lived their whole life with the purpose of pain is to tell you that it's been damaged. And when I have pain, I can either get someone to cover it up, or I can get someone to fix the tissue, or I suck it up. And those are my only options. Like, we're fighting against that the whole time. And I guess that's not really the right word, but we are fighting against that all the time. There will be resistance around that all the time. And our job really is to stop fighting, right? To stop, it's to roll with it more and think about curiosity and what would get you to change your view, instead of thinking all I need to do is give the person this knowledge. And part of the reason I say this all like this is because that's where I came from. I'm a very ideological person. And so this idea of people don't have this knowledge, well, if I give them the knowledge, that's all we need to do, right? It'll change. That's definitely where I've started. And I think, doing all that stumbling is sort of open up other ideas about what we can actually do in a different way to make this more effective.
Yeah, that's actually pretty powerful information. And actually we're starting to wrap up towards the end of the time. So if there was something that you could leave with any clinicians who are watching right now, something that they can take and begin to use in the office with their next patient, what would that be?
I think the one thing would be, use the positive effects of the things that you're already skilled at with patients as an educational agent, right? As a way to educate people about what we understand about pain today. That would be it.
Very simple, but so hard to do.
Well, yeah, I guess the thing that I would start with is, you do the technique to the person, they have less pain, they have better ease of movement. What do? That's amazing. Your pain changed. Let's look for the other things that'll do that too.
And now they'll actually listen to you a little bit more because something's happened, as you mentioned earlier in the discussion.
Yeah, one, and if you get a little bit, if you act a little surprised by it and you get a little excited about it, then I think you'll get a different response, right? But then sitting back and going, oh, of course the person got better. I know this works, right? But what the person experienced was something like, you gave me a pill, you covered it up, you didn't help me get better. The person may not be thinking of it that way, but it probably fits into the person probably fits it into the category of you fixed something, you covered it up, or you're just somehow you're making it easier for me to suck it up. Right. Yeah.
Well, thank you so much for joining us here today, Neil. I appreciate your time. And everyone can read, your bio for more information, and hopefully check out the book when it comes out in August 2019.
Yeah, and then I guess the one other thing is check out our new website is Pain Care U, like U for university, paincareu.com. There's lots of free resources on there as well. The information on how to get the books there as well. So thanks a lot.
Yeah, and we'll link your website too.
All right, great.